I'll go ahead and get started. All right. Well, like I said, good afternoon. Welcome back to our monthly CNE. I'm AJ. Obviously, everyone knows Val. We are going international today, so we're really excited about our speaker. But before we get to that, I'm going to go ahead and do a little housekeeping. So we want you, if you're wanting to get your CNE or CEU credit for this presentation, you must be on Zoom for at least 50 minutes and complete a short competency quiz, scoring 80% or better. We will send out the quiz and an evaluation by email to you later on Friday. So make sure you've added our interim education at Gmail to your contacts. I know for me it popped up into my spam. So if you're not seeing it, please check that out. Make sure that it's not getting flagged. We will be recording this session and posting it on our interim healthcare Topeka YouTube page. So you may view these again later if you wish, but due to the rapidly changing nature of healthcare and practice interventions, please consider all recordings out of date 1 year from the original recording. For next month, I'm going to go ahead and plug it. We have Lacey Cornelison. She's been with us before, right now?
She has. 2023. She was talking about sexuality in long-term care last
Okay,
time.
there it is. It was getting spicy back then.
Well,
She is the interim director of the Center on Aging at Kansas State University, and she'll present on Beyond the Care Plan, using what matters to drive age-friendly care for older adults. So that should be a very interesting topic for next month. But without further ado, I'm going to go ahead and introduce our speaker for today. With us, we have Hazel Haworth. Hazel is a final year PhD researcher at Queen's University Belfast, whose work focuses on improving medication adherence for people living with Parkinson's disease through co-designed digital education. Her research combines evidence synthesis, surveys, interviews, and participatory workshops with patients and carers to develop practical resources that support medication self-management. She also contributes to dementia and brain health research and teaching in dementia care. And just from the little bit of time I've gotten to know her, she's traveled the globe and she has some fascinating stories to share. So without further ado, Hazel, you're up.
Hi, thank you for that amazing introduction. Let me just share my screen here and you can tell me, does that work properly? Yeah.
yep.
Perfect.
Good. Okay. So I'm discussing the challenges of Parkinson's medication management and looking at supporting adherence and understanding in practice. So the session will explore the challenges of managing time-critical and complicated, really complicated Parkinson's medication regimens. And I'll be drawing on research with people living with Parkinson's and their family members who support with medications, based on the last 3 years of my PhD research. And I'm using a behaviour change framework. So I will focus on how health and social care workers can support understanding, confidence, and medication adherence as needs become more complex. So just a brief bit about my actual research. So I'm a doctoral researcher at Queen's University Belfast, which is in Northern Ireland, which is part of the UK, but joined to Ireland, on the island of Ireland. And my research is focused on understanding the challenges of Parkinson's medication management. So I've been conducting a 3-year mixed method study with people living with Parkinson's and their care partners. And the eventual aim at the end of this PhD is to inform the development of a practical behaviour-informed digital educational tool. So we're designing something digital that will educate people with Parkinson's about their medications, but will also help promote really health supporting behaviour. My study design was a UK-wide survey, so I had 509 people with Parkinson's from across the UK complete my survey, and that looked at whether people were actually adhering to and managing their medications correctly, and the short answer to that is no, they're not. And that was followed up with in-depth interviews with people with Parkinson's and carers to find out why people are having such difficulty managing their medications. I also undertook a literature review of what educational interventions already exist to look at what is working and where the gaps are. And I'm just coming to the end of a co-design phase. So that's working with people with Parkinson's and carers to actually design the tool, to look at how it should work, what should be included in it, so that we create something that actually works for these people rather than something that we think will work for them, that then perhaps doesn't. So just a brief overview of Parkinson's disease. Now, I've called it Parkinson's disease here, but I'm only going to refer to it as Parkinson's from now on. And that's because the feedback from the people I've interviewed is that they really don't like the phrase disease. They feel it's a condition rather than a disease. So we'll call it Parkinson's. So Parkinson's is a brain condition that causes problems with movement, mental health, sleep, pain, and a host of other health issues. It's a neurological condition and it's progressive and neurodegenerative. There's no cure for Parkinson's. It's caused by a lack of dopamine in the brain and it can affect people of any age. So there's about 10 million people worldwide at the moment living with Parkinson's, and that's expected to exceed 25 million by around 2050, and that's mostly due to an increase in life expectancy. So there's no cure, as I said, but medications can reduce symptoms. But Parkinson's does result in high rates of disability and a high need for care. Many people with Parkinson's go on to develop dementia. Quite often the two go hand in hand. But interestingly, 10% of people with Parkinson's are under the age of 50. So we call that young onset Parkinson's, although it tends to peak in the 80 to 84 age range group. And you might not know this, but Parkinson's affects many more men than it does women. So there's 1.5 times as many men with Parkinson's than there are women. And globally, disability and death due to Parkinson's are rapidly increasing. And it's also important to remember that people with Parkinson's are often subject to stigma and discrimination, including unjust discrimination within the workplace, especially for those who are younger, and lack of opportunities to engage and participate in their communities as well. So what actually happens in Parkinson's? Parkinson's occurs when dopamine producing nerve cells in the brain gradually die. And dopamine is a chemical messenger that helps control movement, coordination, and smooth muscle control. And as dopamine levels fall, movement becomes slower and more rigid, and symptoms such as tremor and stiffness appear. So dopamine acts a bit like oil in an engine. It allows the brain and muscles to work together smoothly. But in Parkinson's disease, the brain gradually loses dopamine, so the movements become slower and more difficult. And Parkinson's medications work by replacing or mimicking that dopamine. So it's a bit like putting oil in an engine. But unlike topping up oil in a car, dopamine levels in Parkinson's fluctuate, which is why medications have to be taken carefully and on time. And because dopamine levels change throughout the day, the Parkinson's medications must carefully replace or mimic that dopamine. And that's why the timing of Parkinson's medications is so critical. So just a brief overview of Parkinson's progression, and this is using the Hone and Yahr stages. In stage 1, that's the early stage, people will experience mild symptoms affecting one side of the body, and it tends to have little impact on daily activities. In stage 2, mild Parkinson's, symptoms start to affect both sides of the body, and you'll see changes in walking and posture. In stage 3, mid-stage, you'll start to see more loss of balance and increased risk of falls, and daily activities start to become more difficult. Stage 4 then is advanced Parkinson's, and this is where you start to see severe disability and people starting to need significant assistance for activities of daily living. And stage 5 is end-stage Parkinson's. This is where people often become wheelchair or bedbound and generally require full-time care. So Parkinson's is a progressive neurodegenerative condition and symptoms gradually worsen over years. Now, Parkinson's itself is not usually fatal, but late-stage complications such as aspiration pneumonia, falls and infections tend to be the leading cause of death in this group. So To look at the symptoms of Parkinson's, there are actually over 40 motor and non-motor symptoms. I'm not going to go over all of them, but just the most common ones. The first is tremor. So this is the symptom most people think of when they think of somebody with Parkinson's. And the tremor is that involuntary rhythmic shaking, and it most commonly occurs in the hands or the arms while at rest and tends to stop during movement. Then we have rigidity, which is stiffness and tension in the muscles, causing pain and limiting the range of motion. Bradykinesia, which is an extreme slowness of movement, and that can really make daily tasks quite difficult. And sometimes you'll see people walking with small shuffling steps. Postural instability, which causes impaired balance, problems with coordination, and makes people at a higher risk of falls. Then we have freezing of gait. And I was actually talking to someone with Parkinson's on the phone about this just before the meeting, who's just started experiencing this. So this is a temporary involuntary inability to move, often when starting to walk or turning. And the people that I've spoken to tend to have this issue at certain times or places. So one man I spoke to experiences this when he tries to walk through door frames from one room to another. And he explained it as being like a cat with really, really sensitive whiskers, and his whiskers touch the edges of the door frame and then he stops and he can't move. Another man I spoke to experiences this when he's in crowds and there's lots of movement around him. So it's very, very hard to get moving again when you experience that. With microphagia, which is small and cramped handwriting. One lady I interviewed was a primary school teacher, only in her 40s, and this was the first symptom she had. Her handwriting got really small and cramped, and she was trying to teach young children how to write and form letters. So she went to the doctors, and he immediately referred her for tests for Parkinson's. Masked faces is a reduction in facial expression and blinking. So when you're speaking to someone with Parkinson's, you might find that they look like they're staring at you really, really intently. They don't blink, but also they might not have those facial expressions that you expect. So it's oftentimes hard to tell if you've cracked a joke, whether they found it funny, or if they're cracking a joke, you might not know whether they're joking because those facial expressions aren't there. Then we have dystonia, which is painful, prolonged muscle contractions or cramps, and festination, which is a gait pattern. So that's what causes those quick, short, shuffling steps that you often see in more advanced Parkinson's. And then non-motor symptoms, as I said, there are a lot. So these are just some of the most common ones. People often experience cognitive changes. So they might experience confusion, lack of focus, or a really intense focus on one thing that removes their focus from other important things like taking their medication, and dementia. As I said, that's quite common. There are mood disorders, so people experience depression, apathy, and anxiety. Sleep disruptions such as REM, sleep behavior disorder. I have had a lot of people talk to me about how they wake up in the night thrashing and screaming and scaring the life out of the person lying next to them. They might have insomnia or excessive daytime sleepiness. And then sensory issues such as loss of smell, pain, fatigue, excessive sweating, or vision changes like dry eyes and double vision. Then there's constipation, which is a really common problem in Parkinson's and makes the absorption of medications more difficult. Low blood pressure, urinary issues, hallucinations and delusions, speech changes, so that often people with Parkinson's, their speech becomes much, much quieter or more monotone, and sometimes they'll mumble in between words or they'll experience stammering or stuttering. And impulsive and compulsive behaviors. And I'm going to talk about impulsive and compulsive behaviors and hallucinations and delusions in the side effects slide, because they are both a symptom of Parkinson's and a side effect of medications. So I'll explain that in a bit more detail. I want to give you a brief overview of the drugs used to treat Parkinson's symptoms. So levodopa drugs are usually prescribed for someone newly diagnosed with Parkinson's or when mobility problems affect someone's daily life. And levodopa helps improve muscle rigidity and movement, and it's converted into dopamine in the brain and stored in nerve cells to replace that depleted dopamine. And it's usually combined with another drug, so either carbidopa or benzerazide, which allows more levodopa to get to the brain and reduce side effects. But the timing and absorption can be affected by diet, which I'll explain in a minute. So dosing schedules are individualized for each person with Parkinson's. So it's the most effective treatment for Parkinson's movement symptoms. It works by replacing dopamine in the brain. It's usually taken several times a day, but over time, some people experience motor fluctuations or dyskinesia as a side effect of levodopa, but it still remains the gold standard treatment. And it may require a protein redistribution diet. So for some people with Parkinson's, protein can cause problems with how well levodopa medications are absorbed by the body. And these people benefit from having most of their daily protein in the evening, which is what we call the protein redistribution diet. And this can help the levodopa treatment work better in the daytime when you're likely to need it more, but also ensures that people get the protein that they need as an important part of their diet. And levodopa is best taken on an empty stomach, but sometimes this makes people feel nauseous. So if that happens, they should eat a very low protein snack with it. Then we have dopamine agonists. So dopamine agonist drugs trick the brain into thinking they're dopamine. And this means they can mimic the way dopamine works, which can reduce symptoms. And dopamine agonists are generally prescribed in the earlier stages of Parkinson's. And it has to be started carefully and the dose gradually increased. So the benefit to using this medication is that you don't need to take as much levodopa, which comes with side effects such as dyskinesia. And they can be taken with levodopa as well when levodopa wears off or isn't working as well. And most of those listed on the side there are oral tablets, but apomorphine comes in like a pump. So somebody's having particular issues with their levodopa drugs not working long enough in between doses or having lots of symptoms coming back, they can have an apomorphine pump fitted, which provides a steady stream of levodopa throughout the day. And they can also press like a little button on it to give them a bit of a boost if they need it. So the last few Parkinson's medications are monoamine oxidase B inhibitors, and they block an enzyme that breaks down dopamine and helps the dopamine last longer in the brain. And it helps reduce off time when combined with other medications. And I'm going to tell you a bit more about what I mean by off time in a minute. Then we have COMT inhibitors. They're used with levodopa to make it last longer and help reduce wearing off between doses of levodopa, which is that off time. And they block the enzyme responsible for breaking down levodopa before it reaches the brain and improves the duration of the response to the levodopa medication. Then we have amantadine, which is used to manage dyskinesia, which is a side effect of levodopa. It enhances dopamine release and blocks glutamine, and is usually used to treat early symptoms. And anticholinergics, and these are older drugs mainly used for tremors, but they're used less often now because of the side effects, which tend to be cognitive side effects. And so when they are used, they tend to be in younger people and not the older population. So there isn't a single medication for Parkinson's. Instead, treatment usually combines drugs that replace dopamine, mimic dopamine, or help dopamine last longer in the brain. And some people will opt to have deep brain stimulation or DBS. So this is a surgical treatment used for some people with Parkinson's, where electrodes are placed in specific areas of the brain, and these are connected to a small battery device in the chest. And that device sends electrical signals that help regulate abnormal brain activity. So it helps control motor symptoms such as tremor, stiffness, and slowness, and it can reduce off periods and medication fluctuations. It often allows people to have lower doses of their medication. So some people think DBS is a bit of a cure for Parkinson's, but it's not. And they think if they have DBS, they won't need to take medications anymore. That's not how it works, but you often can move to a lower dose of medication. And it doesn't stop progression of the condition. And it works best for people whose symptoms respond to levodopa, but who have severe fluctuations or dyskinesia caused by levodopa. And it's important to know that there's a sort of time slot that you can have DBS. So you can only have it once, and the device will only work for a certain period of time, so maybe 10 years or 20 years if you're lucky. So you don't want to have DBS too early if you're a younger person with Parkinson's, because the benefits of it will run out and you can't have it again. But they also don't like to perform this on people over a certain age as well. So it's kind of a window of opportunity when DBS becomes suitable for people. So I want to talk about the medication side effects. When I was interviewing people with Parkinson's, they really, really struggled to know whether what they were experiencing was symptoms of Parkinson's progressing or side effects of the medication they're taking. And from talking to them, I can understand that it's really, really difficult to tell the difference. So hallucinations and delusions are both a symptom of Parkinson's and a side effect of medication. And hallucinations can be auditory, they can be tactile, they could be present, so the feeling that someone is there when they're not. It could be hallucinations of smells and tastes, or visual illusions, so seeing things differently from how they actually really are. But it can also happen due to a type of dementia called Lewy body dementia, which is more common in people with Parkinson's as well. And in delusions can be things like paranoia, jealousy, grandiose beliefs, wrongly identifying people, places, and objects. Then we have dyskinesia, and this you've heard me mention this a few times already. So this is a side effect caused by levodopa, and it's uncontrollable muscle movements. So it can be mistaken for Parkinson's tremors, but dyskinesias tend to develop after years of taking medications or earlier if you're on a high dose. And whereas a Parkinson's tremor is kind of rhythmic movement, rhythmic tremor which reduces with movement, dyskinesias are unsteady and disorganized, and movement actually makes them worse. And if someone's experiencing dyskinesia, that can be helped by moving to that protein redistribution diet or having deep brain stimulation. Then we have impulsive and compulsive behaviors. And this is something that the people I've interviewed are really, really worried about, the side effect that causes these behaviors. And I've talked to people who need to up their dose of Parkinson's medications. Their symptoms are getting worse, and they won't tell their consultant because they're too afraid that if they up the dose of Parkinson's medications, they're more likely to get this side effect of impulsive and compulsive behaviors. So they're not getting the treatment they need because of that fear. And these can be things like gambling, hypersexuality, binge eating, obsessive shopping, punding, which is like repeatedly carrying out an activity that serves no purpose, hobbyism, so real extreme focus on hobbies, hoarding, or dopamine dysregulation syndrome, which is taking more medications than you need through an addiction to how it makes you feel. And there are a host of other medication side effects here, gastrointestinal ones, autonomic ones, motor, neuropsychiatric, and sleep and alertness side effects as well. So these side effects can vary between individuals, but medications can usually be adjusted to help manage them. Although it's really hard for people to know when they need to talk to their consultant about side effects, because as I say, they often don't know whether it is a side effect or a symptom or a progression of Parkinson's. So you've heard me talk about on and off symptoms in Parkinson's, and I just want to explain what I mean by that. So people with Parkinson's often describe their day as switching between on times when medications work and off times when their symptoms return. And on-off symptoms describe fluctuations in how well that Parkinson's medication is working. So as Parkinson's progresses, medication effects may not last long, and the dopamine levels start to fluctuate in between doses, and this can lead to wearing off periods. It can also happen in the early stages of Parkinson's as well, where the consultant is trying to work out the exact timing of medication for that person, sort of trialing it to see if it works for them. So if you look at the diagram at the bottom, you see somebody takes their dose of medication and they go into an on period where the medication is working properly and they feel well. But that medication might not work until the next dose, which could be maybe 3 or 4 hours later, and it wears off. So they go into an off period where their symptoms return until they get to the time for their next dose when they go on again. And what that means is that people have to manage their lives around these on and off periods. So if somebody has an appointment, if they're going to get their hair cut, they will time that appointment to be just after they've taken their medication so that it's in that off on period and they can get back home before it starts to wear off. And in extreme cases that I've seen, sometimes people have quite long off periods and they can't even reach their medication. I've heard of people crawling across the floor to get their medication when they're in an off period and worrying that they're going to freeze before they get it. So just to put this all into perspective, I want to show you a typical Parkinson's daily medication schedule. So you have the symptoms that are being treated on the left and the medications used to treat that next to it. And then you have a typical Parkinson's daily schedule on the right. So can you imagine that you're trying to go to work or bring up a family, which some people with Parkinson's are doing, or have an active social life or enjoy your retirement when you are committed to these time slots throughout the day and remembering each of those time slots? It's really, really quite challenging. And Parkinson's medications have to be taken on time. And according to the World Health Organization, that means within half an hour of the prescribed dose. You've got kind of a half an hour window, which can be you can be easily distracted from that. Say if you take a phone call or somebody comes to the door or something happens. And as well as this, people may be taking medications for other conditions. So things like diabetes, heart disease, arthritis, and dementia are really common in people with Parkinson's. So they may have other medications on top of a schedule like this. So why does medication adherence matter in Parkinson's? Well, Parkinson's medication regimens can be very complicated and, as you've seen, are very time sensitive. And some of the people I've interviewed have been taking 30 or more tablets a day just for Parkinson's, and they need to be taken at the correct time. So Parkinson's patients require the complex time-sensitive regimen of medications. Previous research shows that up to 70% of Parkinson's patients struggle to comply with these regimens. And the result of that then is they experience medical complications, harm and increased disability, but it also causes extra burden and cost to the health services. And I want to give you an example of a gentleman I learned about in my interviews. I spoke to his son. This man was now in a care home, but his son told me that he never really understood how important the timing of medication was. And this man's wife used to manage his medications for him, give them to him at the right time. But he had a tendency to leave the house and go on long walks without his medication. And one day he went for a walk along the beach. He lived next to the beach, and he didn't get back in time for his medication. And he froze. He completely froze on the beach and became unable to move and was lying on the beach when the tide started to come in. And the tide came up around him and he thought he was going to drown. He was calling out for help, and only that somebody was walking past and heard him calling that they were able to save him. So it really can be quite serious if somebody doesn't get their medications on time. So the challenges of managing Parkinson's medications, obviously it is a challenging regimen, but there's more to it than that as well. So the survey that I conducted across the UK, I found that under 5% of the people who completed the survey were actually fully adhering to their medications. So 95% of those people with Parkinson's were experiencing some level of challenge, and about 15% of them, it was really extreme non-adherence. But interestingly, I also measured self-efficacy scores. So I measured how confident people felt about managing their medications. And that data showed that people actually felt reasonably confident about managing their medications, even though the adherence data showed that they weren't managing their medications. So that was really interesting, which is why we did the interviews then to find out, well, if people feel they can manage their medications, why are they not achieving this? And I will talk about that in more detail. But we found that managing Parkinson's medications is rarely an individual task. It involves people with Parkinson's, carers, health and social care professionals, and really good supporting routines and systems. So we found that medication adherence is difficult. Having confidence in your ability to do it doesn't solve the problem. And the problem is complicated and shared. We also found that carers are central to medication adherence, but are often unsupported and invisible. So carers often took on a significant responsibility for medication management. They were doing a lot in the background. They were organising and ordering medications, preparing doses and pill box organisers. They were reminding and monitoring timing, tracking symptoms and medication effects, and stepping in when cognition or symptoms fluctuated. Yet, despite this responsibility, carers frequently reported receiving very little education or guidance about Parkinson's medications, so they felt really underprepared for this role. They said they had limited education or guidance. They experienced anxiety about getting medication timing wrong when they knew how important it was. They had uncertainty about dose adjustments and symptom changes, and they felt an intense responsibility for maintaining complex medication routines. And they also expressed a real desire to attend clinical appointments. And this was something where there was a bit of a difference between the people with Parkinson's and the carers. So quite often the person with Parkinson's wanted to remain independent and autonomous for as long as possible and would go to appointments on their own. But that meant that the carer partners, family members didn't learn about medications, didn't learn about the importance of them, didn't learn about really important things like not eating protein at the same time as taking medications, or how important it is to drink a lot of water with each tablet, because people with Parkinson's have such difficulty with constipation. You need to drink a lot of water to help that medication get into the system. So they weren't learning about these important things, and they felt it was really important that they could attend appointments to learn about this as well. And we learned then that medication adherence in Parkinson's is shared work. So carers often coordinate medication routines behind the scenes. And what we learned was that when we interviewed the people with Parkinson's, they felt they were very, very independent with their medications. But then when we interviewed their husbands or wives or sons or daughters, there was a lot more going on behind the scenes to support that than they were aware of. And their families were really trying to help them maintain their independence, but also be supportive at the same time. And carers' strategies and beliefs can influence adherence. So supporting adherence requires supporting carers as well as patients. But not everyone has family support, which highlights the importance of having wider systems of care as well. So medication adherence is a behaviour, and like any behaviour, it's shaped by capability, opportunity, and motivation. So after I interviewed the people with Parkinson's and their family members and did my analysis, I redid my analysis using a behaviour change framework called COM-B. And COM-B stands for capability, opportunity, motivation, and behaviour. The three all feed into behaviour. So to better understand the challenges, I analysed everything I learned about medication against this framework. And just to explain what I mean by each of those. So for capability, we were looking at the person's psychological and physical ability to perform the behaviour. They needed knowledge and understanding required for the behaviour, cognitive skills such as memory, attention and planning skills, and physical capacity to carry out the task. And this COM-B model is really useful for all different aspects of health behaviour, not just Parkinson's medications. In terms of opportunity, then, that means external factors that make the behaviour possible or support it. So things like environmental resources and practical supports, social influences such as carers, family and professionals, and systems and structures that enable the behaviour. And motivation then looks at internal processes that drive and sustain behaviour. So beliefs and attitudes about the behaviour, intentions, decision-making and planning, and habits, routines, and emotional responses. So our COM-B analysis showed that medication adherence wasn't simply about remembering the tablets. This is why people felt that they could manage medications but weren't. It wasn't just about remembering that complicated schedule. It depended on knowledge, environmental supports, social scaffolding, and deliberate decision making. So these challenges then, they're not just about knowledge or motivation. They reflect the behavioural demands of managing complex routines. So just to look at these again, if you imagine that somebody has the capability to manage their medications, they've got the knowledge and the understanding, they know why they need to take their medications on time. And they've got the opportunity. So they have family support, they have alarms and reminders, they have good professional support, but they're missing something in motivation. Maybe they have a negative belief about their medications. If there's something missing in any one of those categories, it's really difficult to achieve medication adherence. So they might have the motivation, they might have the capability, but they don't have the opportunity. They don't have the reminders set up on their phone. They don't have the family or professional support. So you need all of these areas covered to actually be able to manage these complicated medication regimens properly. I hope that makes sense. So this is what we found when we analysed it in terms of capability. We found that medication adherence is not just about patient knowledge. It requires cognitive scaffolding and practical support systems. So what do I mean by that? We found that medication management creates a substantial cognitive workload. There's a lot of planning involved in planning your life around these medication routines. You have to remember time rings, you have to monitor symptoms, you have to interpret side effects, and this all involved a sustained cognitive effort in a condition where cognition can already be affected. We found that memory alone is rarely sufficient to maintain adherence, so many people relied on external cognitive support, such as alarms on their phones, pillbox organisers, notes, and reminders. We found that cognitive difficulties may be subtle, but still affect adherence. So even people who are relatively cognitively able could experience challenges. So even mild memory lapses or confusion around timing can lead to missed or delayed doses. And people often develop their own compensatory strategies over time. So what I mean by this is that through time, they were learning, they were experimenting, they were adapting to their bodily symptoms, their bodily cues, and developing their own role in managing these complicated medication regimens, which sometimes worked really well and sometimes didn't, because sometimes they'd make changes that weren't correct. We found that physical symptoms interact with medication timing. So things like fatigue or return of tremor or going through off periods made adherence harder in daily life and made people change when they took their medications as well, sometimes complicating things further. And we found that the body itself could act as a cue for medication. So for some people, the return of symptoms would prompt them to take their medication. They'd realise they'd forgotten to take it. And other people relied on no reminders whatsoever. They tended to be people who'd had Parkinson's for longer and could just feel within their body that their next dose of medication is due. So what did we find in the category of opportunity? Well, adherence in Parkinson's is socially and environmentally scaffolded. It's not simply an individual behaviour. So what do I mean by that? We found that environmental supports are often the most practical facilitators of adherence. So the use of things like alarms, pillboxes, having structured routines, having backup medical supplies, so people would have extra medications in their car in case they didn't get home in time, or in their families' homes, or in different rooms in the house in case they experienced an off period and couldn't get back to their medications on time. And these things all helped them to stabilise their medication use. We found that adherence frequently depended on carers. So many carers organised medications, provided reminders and maintained routines, especially as Parkinson's progressed. The medication adherence is often co-managed rather than managed by the individual. So family members, partners and professionals all form part of a support system that helps sustain adherence. But breakdown in environmental systems quickly led to missed doses. So although things like alarms and family and professional support and reminders all helped, if there was a breakdown in that routine, so as I said, if somebody had to go out for the day and their routine was different, or somebody came to the door and distracted them, or if they had to travel, there was terrible difficulty with traveling, especially through different time zones, or hospital admissions. A lot of people talked about having the medications taken away from them in hospital and they're used to managing themselves, which caused extreme anxiety. So if people had good routines, it helped, but it was very easy for those routines to be broken. Access to professional support between appointments was really important. People really valued reassurance and guidance, but in general, they knew that their health and social care professionals have Parkinson's nurses here to support people and their consultants. They knew that they were under intense stress and had really high caseloads and really felt like they were taking time away from them if they made appointments. So they need that support, but they felt guilty asking for it. And we also found that support networks can create tensions around independence. So reliance on carers. People often relied on carers or tried not to because it raised concerns about having autonomy or control over their own independence and their own condition. So in terms of motivation, we found that adherence is driven by deliberate reasoning and fragile habits, both of which require ongoing support. So what do I mean by that? People with Parkinson's actively reason about their medications. So their decisions about timing, dosing, and adjustments, if they made changes to those, were often very deliberate and very reflective. Their beliefs about medication effectiveness strongly influenced adherence. So doubts about the benefit of their medications or concerns about the side effects reduced motivation. So what we found was that for those people who took their medications and really didn't feel much difference, they were far less likely to take them on time. For those people who took their medications and felt an immediate relief of symptoms, they were far more concerned with taking their medications on time. Many people do make a conscious effort to stay on track. They put a lot of effort into planning ahead, setting boundaries around timing, so only organising social activities and things like that around the timing of their medication and maintaining routines, but that all required a real sustained effort. We found that habits can stabilise adherence when routines are consistent. So medication taking became automatic when people had established daily structures. So if somebody did the same thing every day, their routines remained consistent. But it was when routines changed, they had a wedding to go to or a holiday to go to, that could really disrupt things. But we found that habits are fragile. So as I was saying, disruptions to routine or distraction quickly led to uncertainty about whether medication had been taken. And I had quite a few people say to me that taking their medication had become so automatic that their alarm would go off, they'd pop a pill so subconsciously that 5-10 minutes later they couldn't remember whether they'd taken it or not. And then they didn't know whether they should take another one or wait to see if their symptoms returned. So even when people had those routines, it was still very fragile. And positive symptom relief reinforced adherence. So I kind of covered that already, but those who experienced a benefit from taking their medications tended to be more adherent to them than those that felt they weren't getting the full benefit. So I have a couple of just quotes from the interviews to help put that into perspective, what people told me. So somebody, this was a lady, said, medications can get changed, which can throw a spanner in the works. You've got used to a certain way. So this lady had been taking her medications every 3 hours for years. Then she got deep brain stimulation and it got changed to every 4 hours. And she just couldn't get used to that new routine. It really threw her off. Somebody said, I play about with my medications a bit. But when I told the consultant, he was like, no, right, stop doing that. I'll give you a slow release. So people often, if they felt their medications weren't working properly, they'd play around with them a bit and think, well, when I go to the consultant, I can tell him this way works better than the way you prescribed. But they don't necessarily realize that there's maybe other options like having a slow release tablet instead. You know, it just depends on how I feel. I mean, people say about taking your medications on time, but I take them whenever I feel I need them, you know? So not everybody was strictly following their routines. Some people did follow them as if they were, you know, sent from the Bible or something. They were so important. Other people were far less likely to do that. When I go to see him, he says to me, okay, so what are you taking? Not what's on the list, what are you actually taking? And this kind of shows how clinicians and consultants, they have to spend a lot of time working on each individual person's medication routine. And if the person is taking them differently, that really challenges them being able to fine tune when the person is taking it. And they often know that they're not taking it as they should. And this is a carer who said, because her mind's set on something else, she's very one-tracked at the moment with her Parkinson's. If she decides to do something, we have to do it, and then she might forget her medication. So that's about that sort of focus that takes people away from actually taking their medications. So very, very quickly here, just to show you how if capability, opportunity, and motivation all come together and you have everything you need in each of those domains, you can get stable medication adherence. But if not, that's far harder to achieve. So what actually helps people manage their Parkinson's medications? Well, what participants told us very clearly was that medication management doesn't happen in isolation. Confidence comes from a web of reliable support from family, professionals, and routines all working together. So that reliable support builds confidence. People feel more confident managing their medications. They told us that person-centered support really matters, and that support needs to be individualized, practical, and adapted to changing symptoms and ability. And they told us that integrated care makes a real difference. So people really valued coordinated support across professional services and carers rather than fragmented advice. People were often getting advice years after taking medication from different sources rather than receiving all the advice they needed at the start. So we found that education does improve medication adherence, and even a really, really basic understanding of medications improves adherence. People don't need really like encyclopedic knowledge, just basic understanding. And that helps reduce negative beliefs and concerns about treatment. Education or learning about your medication supports safer medication use. So people showed an increased vigilance in avoiding missed doses or overuse when they understood the importance and of their medications and why they needed them. And that improved coping skills and self-management strategies. And education built confidence and partnership. So when people understood their medications more, they felt greater ownership of treatment decisions, improved self-efficacy, and a stronger therapeutic relationship with clinicians. So when people understood about their own medications, that really fed into more positive clinical appointments as well. So just looking at medication management in advanced Parkinson's, as Parkinson's progresses, medication management becomes a careful balance between symptom control and avoiding side effects. So they use medication rationalization. So non-essential medications may be reduced in the late stages of Parkinson's, which helps minimize polypharmacy and agitation. But it's really important to avoid sudden withdrawal, especially of dopaminergic medications like levodopa. Sudden withdrawal can cause Parkinsonism hyperpyrexia syndrome. And that's rare but serious complication caused by this abrupt withdrawal. And the symptoms include severe rigidity, fever, altered consciousness, autonomic instability, and it can cause death. And sometimes people need alternative routes to their medications in advanced or end-of-life Parkinson's. So they may have swallowing difficulties that require dispersible formulations or transdermal rigatine patches instead. But one of the most important safety points is that Parkinson's medication should never be stopped suddenly, even near the end of life. And dopamine blocking drugs should be avoided as well, obviously. So end-of-life care for Parkinson's focuses on comfort, dignity, and quality of life rather than curing the disease. And the key priorities are symptom management, so dealing with pain, breathlessness, excess respiratory secretions, and anxiety or agitation. There's a focus on nutrition and swallowing, so dysphagia is common in the later stages, and this can lead to natural decline in eating and drinking, but artificial feeding may not improve survival rates or prevent pneumonia, so it's often not appropriate. Prior to this, people need to look into advanced care planning, discuss goals of care early, and consider things like lasting power of attorney. I'm not sure if you call it the same thing in the US as we call it here, so I don't know if that's appropriate. It probably is. And hospice care is typically considered when life expectancy is 6 months or less. So when there's rapid functional decline, when there's repeated infections or hospital admissions, or significant mobility deterioration. So I hope this has been useful. I just wanted to provide some key takeaways for you for practice. I feel like I've raced through this and you're probably completely overwhelmed with the amount of stuff I've told you. But medication regimens in Parkinson's are complex and time sensitive. So delayed or missed doses can significantly worsen symptoms and quality of life. Medication adherence challenges are common. They're the norm in Parkinson's, and most people with Parkinson's will experience some difficulty. Medication management is shared work, so people rely on carers, they rely on routines, healthcare professionals, all of these things to maintain their adherence. It's very hard to do it just on your own, just through remembering. Behavioural factors shape medication use. So people need capability, they need opportunity, and they need motivation. These all influence how their medications are taken in daily life. And education and practical support improves medication management. So clear information, having routines, reminders, and coordinated care can strengthen adherence. And again, the research shows that even a very basic education, basic knowledge can make such a difference. So to summarize, what my research shows is that medication adherence in Parkinson's isn't simply about remembering tablets. It's a complex behavior shaped by symptoms, routines, beliefs, and the support that people receive. So through education, people need to understand their medications. Behavioral support, they need routines, reminders, and coping strategies, and integrated care, patients, carers, and professionals all working together. So medication adherence is a system. It's not just down to one person. And I thought I would end before, see if you have any questions as well, but I thought I would end by just showing you a lovely photo of Queen's University here in Belfast, Northern Ireland. Isn't it just absolutely stunning? I can't believe I get to go here. So I've just added my contact details on the side as well there, but if anyone has any questions, I can't promise that I'll know the answers to them, but I'll certainly give it a try. So I'll stop sharing this. Is there anybody here?
Well,
It
again,
suddenly had a moment there where it looked like everyone had gone. Oh my goodness, they've all left.
they were still all in awe of the beautiful building you get to call home. That's what it was.
Yeah.
But again, we just have a couple more seconds. Anybody has any other suggestions or
We
questions?
have a couple questions, I think.
All right.
Can you scan it?
Yeah,
first there?
absolutely. All right. Let's see what we got. Can you give more information on how proteins and diet can affect the medications?
It's, I couldn't give you really, really detailed information on that, but basically, protein stops the absorption of levodopa. So when somebody takes their tablet, and most people that I interviewed are just taking their tablet with a meal, because most times you get medication, it says take it with food. So they do that. But the protein then affects the absorption of the dopamine into the brain. So somebody's taking their medication and then they're not actually getting the benefits of a certain amount of that drug. So, but it's really, really important that people get their protein. You know, you need protein. So we need to make sure people with Parkinson's are still getting their protein, which is why then we look at having a very low protein diet during the day. So during the day when you need to be active and you need those medications to work as well as possible, you have low protein meals. In the evening when you're starting to wind down and you're going to be far more relaxed, you can have as much of your protein as you can get into your day at that point. And that gives the daily medications more time to work. And most people in the evening before they go to bed take a slow release levodopa as well, which is released far more slowly and copes better with that protein intake. So I'm not sure if that's answered that question. Scientifically, I couldn't give you a very in-depth reason for why protein affects the dopamine absorption.
Thank you. Another question we have is, do you have any suggestions on how to motivate limited education staff to give meds on time?
It's such a challenge, and it's a challenge we have here too, especially in care homes and hospitals. So my experience is here, hospitals and care homes have medication rounds, so they have a time of day or certain times of day where they go around with medication, and that's when people get it. In terms of Parkinson's, that just doesn't work for people. We do have a policy here in the UK that people with Parkinson's, if they're cognitively able to do so in hospital, should be given their own medications to continue taking at the times they would usually take them. But it doesn't happen. A lot of the time, their medications are taken off of them. And then you hear all of the time about how they're ringing their buzzer to tell the nurse, I need my medication. I'm wearing off. It's wearing off. And they feel like a nuisance. Somebody told me recently they just felt like they'd been branded as a troublemaker when they were in hospital because they just kept asking for their meds on time and it wasn't time for the ward round. So it is really challenging. What we're hoping to do in this digital tool that we're making is have a page written by people with Parkinson's that they can show on a screen to hospital staff or care home staff when they're there that says about the importance of taking medications on time. So I think really, as long as staff can, if you can explain to them that on-off period and how if somebody doesn't get it on time, it's not like other medications where, you know, if you take it every day, you're generally okay. It's so time sensitive that if you don't get it, your symptoms come back completely and sometimes catastrophically. Um, and then that's going to be more work for hospital or care staff dealing with a person whose symptoms have come back. So if you can get just a basic understanding of that, I think it's going to help. But I wish I had a solution, magical solution for that.
Looks like we have another question. Is it possible that the neuropsychiatric symptoms would present first?
It can be, in general, from what I have spoke to about people, the first symptom in that kind of category that came was the sleep disturbances. So do you remember I said about people waking up in the night screaming? And really going from being in a sleep to absolutely screaming as if you're being attacked and oftentimes attacking the person next to you. A lot of people with Parkinson's experienced that many, many, many years before they experienced any kind of tremor or other symptom. But in general, those kind of neuropsychiatric ones would be it would be more obvious in more advanced Parkinson's. So as Parkinson's progresses, you're going to see more real cognitive issues like dementia. But what you see in the early stages is that the difference in focus. So if I can explain, there was one man I was speaking to who was diagnosed in his 40s, and he noticed that he would become really, really preoccupied with something like the fact that the floors needed to be mopped when he actually had a full day of work to do and children to pick up from school. But that would take his entire focus, and he couldn't do anything else until he got that sort of one thing out of the way. So you can see things like that early on. Um, but most people, it's the tremor, the change in handwriting, speech changes as well. Quite often people notice changes in their speech becoming very quiet before any kind of tremor or anything would start to appear.
All right. Well, thank you. It looks like you have answered all the questions that have come in from the gallery so far. So we'll go ahead and wrap this up. But again, we really appreciate your time. That was incredibly insightful. Judging by the questions and the responses we're getting right now in the comment section, seems like everyone else really enjoyed it as well. So thank you so
No
much,
worries.
Hazel. And just one more, we just want to plug. We will be having Lacey Corneliuson. Talking about beyond the care plan, using what matters to drive age-friendly care for older adults coming up in April. That will be Zoom only as well.
That will be Zoom
All
only,
right.
and she is the interim director of the Center on Aging there at K-State.
All right. Well, thanks everyone. And you want Hazel to
Just
stay
for a
around?
sec,
Hazel, if you
yeah.
don't mind sticking around, and everyone have a great afternoon. Thank you.
Thank you, everybody. Thank you.
And